Good morning, everybody. This is Chris Hislop from the Montana World Affairs Council coming to you from Missoula, Montana. Thank you very much for joining us on Connect Montana. This week is Public Health Week, and we're very pleased to have two extremely experienced and interesting guests. Our first today is Dr. Jennifer Westrup. She is the Director of Oncology and is a Consultant Medical Oncologist at Beacon Hospital in Dublin, Ireland. She was appointed Associate Clinical Professor at University College Dublin and sits on the steering committee of the innovative UCD Beacon Academy. Dr. Westrup is also the former medical director at Beacon Hospital and the awardee of the coveted Bronze Otter Award. We will now hear from Dr. Westrup for about the next 10 to 15 minutes, and then there will be a chance for you all to ask questions via the chat function on Zoom. Over to you, Dr. Westrup.
Good afternoon. Listen, a very special thank you to Chris and to the Montana Global Affairs team for inviting me on this podcast, and I'm very happy to support your mission. It's an important one. So today, in the next 15 to 20 minutes, what I hope to do is talk to you as a doctor and an oncologist, and also as a healthcare worker who returns home every evening, and talk in particular about this evolving pandemic. Now, I don't want to rehash any of the headlines, but what I'd like to do is give you some insight into how doctors like myself and my colleagues are thinking about this, how it evolved, how it's changing our practice, and what we might learn in the future. And in doing so, we note that there's a couple of key timelines. Now, I'm sorry, I'm just going to pull up my video a little bit higher so I can see you. But a couple of the key timelines that we watched and really got our attention as doctors happened in January, around the third week of January, when the Chinese reported that they were going to build 2 hospitals, bricks and mortar, from the ground up in a period of 10 days. Now, any doctor who works in a hospital will tell you that even if you want to repurpose an outpatient center, it takes 6 to 9 months to get in the equipment that you need for doctors and for patients to work. Everything from oxygen to medical equipment and supplies. So it immediately got our attention when there was reports that they were going to build a hospital, not 1, but 2, in a period of 10 days. The second milestone that we saw that really got our attention was on the same day. Our biggest publication that we follow is the New England Journal of Medicine. And this publication started reporting case reports on a novel respiratory virus in China. Now, those 2 things were enough to get our attention. And I'll tell you that most doctors were not infectious disease specialists, microbiologists, or public health specialists. But we all have a real respect for infectious diseases. Not only do we see them in our communities, but we're really aware of them in our hospitals. And we all trained in infectious diseases early on in our medical school years. And a couple of things that really caught the attention was, number 1, this was being reported as a respiratory virus, and that it was able to transmit through aerosol and droplet transmission. The second was that it was contagious during the incubation phase, when most people don't realize that they have symptoms. And the third was that it was entering a human population that was naive and didn't have any immunity to this virus. So I would have to say that in January, as doctors, we were already starting to be a bit concerned about this. Within 2 weeks, the first death was reported in a healthcare worker, and that was a 33-year-old ophthalmologist from Wuhan. And what really caused unease amongst doctors was, number 1, ophthalmologists are rarely at the forefront of an infectious disease outbreak, epidemic, or pandemic. And number 2, 33-year-olds rarely succumb to viral illnesses. And that milestone was the milestone that started making doctors worried for patients globally, for vulnerable patients, for themselves and for their colleagues. And there's been a lot reported about personal protective equipment. I'm not going to delve into it deeply, but this is how, when this started to evolve, where this concern started to come from immediately. I'm going to step back a week. On January 31st, Italy started reporting its first patients, which gave us the sense immediately that this had global transmission as well. And they acted very quickly, as the Chinese did when they started building hospitals. Is the Italians shut down the airspace with flights between China and Italy. That was a critical move and a really bold move. And I have to say, if any of you are watching the CDC or the World Health Organization, you'll see a few people talking from time to time. One is Dr. Michael Ryan, who is an Irish-trained surgeon, and he's also a public health specialist and the executive director of the World Health Organization. And what Dr. Michael Ryan says, he has a mantra, 3 mantras for an outbreak, an epidemic, or a pandemic. The first is work fast. The second is have no regrets. And the third is perfection is the enemy of good. So both the Chinese and the Italians showed that they could work fast, and it really got doctors' attention worldwide that this was transmissible, this was virulent, and people were working quickly. Now, the rest in the last almost 8 to 10 weeks has been played out right in front of us. We've seen Italy with the clusters in northern Italy, quarantining them, and then almost 5 to 6 weeks later, actually locking down all of Italy, 60 million people. And being in Ireland, that was important because there is a big rugby match between Italy and Ireland every year, and that was on the weekend of March the 6th. The rugby match was canceled, but the flights weren't. We didn't think quickly enough or act quickly enough in that case, and I think there are time points that we'll look back on and wonder if we could have done things better. By March the 12th, Ireland had already shut down our schools, and by March the 20th, we too were in lockdown. So most of Europe was experiencing this, and we were watching as it moved to America. Now, I'll make one note here is that in much of the world, it's called lockdown. In America, it's shelter in place. In Ireland, we call it cocooning. It's a great country. So we've been cocooning for some time now. I would say also that we are learning in real time as doctors, and what we've found is how important it is to communicate globally. So there have been webinars, Zoom calls, and conferences between, we've been speaking to doctors in China, South Korea, Italy, Germany, Spain, and France, in order to try to stay ahead of this virus, learn what they did, and then try to improve on what they've done. One of the most surprising milestones happened just recently. On March 30th, the Irish government took over all private practices, all doctors' private practices, and all private hospitals. Now, just a little background here is Ireland is a country that has socialized medicine for all. And we also have about 50% of the population that buys private insurance, acts for operations or elective things or certain types of care. And these tend to be orthopedic procedures, cardiac procedures and cardiothoracic surgeries, and also cancer care. So I guess I would say never in my lifetime did I think that I would suddenly be taken over by the government, but it has happened. And we're working as one giant system to try to protect our population. How it turns out and what the outcome will be another podcast for another day. So I would say in general, just for this first part, is how we saw this as doctors coming towards us, how we were able to reach globally to our colleagues, and how we also reached back to our medical school days and understanding how to work quickly in an outbreak or an epidemic or a pandemic. Now, my real job is that I'm an oncologist and I care for very vulnerable patients. And they're vulnerable for a lot of reasons, but one is that cancer makes your immune system a little bit lower. But also, cancer treatments can affect your immune system, and this includes surgery, radiation, chemotherapies, immune therapies, novel therapies. So we learned from the Chinese experience, and they published this paper that 18 patients with cancer in China and how they did with the COVID-19 virus. And they helped us to understand that we need to categorize our patients and do it quickly, and to get them into categories of aggressive, curable cancers all the way down to maintenance therapies, and not only look at the patient and the cancer and the treatment, but also to understand the comorbidities and what the home situation was about and what age our patients were, because all of those were risk factors. So we learned to make individual decisions on our entire patient population. And during every week, we are changing and adjusting to each patient and each situation. But we're in the middle of a pandemic, and many cancer patients need to continue to get treatment. So what we've done is we changed a lot of things quickly. We moved everything out of the hospital setting so patients didn't have to be exposed to any further risk than needed, and anyone who could gets blood draws, oral chemotherapies off-site. The second thing we did is we went to video consulting. I thought this was about 2 years away in my practice. It happened in 1 week. I never did a video consult before this, and now it will never leave my practice. We've also split our teams in half to avoid exposure to any part of our team to any particular patient. And this makes it more difficult to work because you're working on half the numbers, but it's safer. We've also changed our assessment stations so patients have to go through a triple lock in order even to get to where their cancer care is delivered. We've gone back to using baby monitors in hospitals, and these have been fantastic. Who would have known? I've gone back to the days of a baby monitor. But for patients who are isolated, having a monitor with a screen outside the room and inside the room is really helpful to them and to their medical teams, because it reduces the exposure of who needs to go into the room. What are our outcomes so far? Well, we've had cancer patients who have contracted COVID, and in fact, some of them do very well. And we're learning as we go along what drugs to use and how to support them. But the other outcome I've found is that the dynamics of our oncology staff is extraordinary. These are people who come back to work every day in the toughest of circumstances, but also in a pandemic. So we've learned how to trust our specialists. We all wanted to put PPE on from head to toe and just live in bubble suits. But we've learned that actually healthcare workers do it best. We know how to wash our hands. We know how to distance. We know how to keep our hands out of things and not put them to our face. So we keep reminding each other every day, we can do this. We do it better than most. We just got to keep at it. There's been no major staff infections, and there's been a low rate of absence from work. Finally, as a healthcare worker who goes home every night, this has provided another new insight into a pandemic. It's not easy. A lot of us have teenagers, and teenagers get their own news, and they see about healthcare workers getting sick. They see very graphic views. They see healthcare workers writing wills and making a list of contacts and passcodes and things like that. We talk about that regularly, and I remind them that this is what we're trained to do. We're not heroes. We're just doing our job on the front line, and we try to do it as best we can. The upside of a pandemic for kids who have been out of school is they've embraced online learning. I'd love to see more of that. Just as we're learning to do things differently in healthcare, perhaps education will also learn the same thing. I've also found that my kids are more well-rested than they've ever been. And in fact, they're getting bored, so which means they're actually getting creative. So I would leave you with this. There are probably 3 main things that I've learned in the evolution of this pandemic, besides Dr. Michael Ryan's mantras, which again, I will say, be fast, have no regrets, and perfection is the enemy of good. The others are really to prepare. We know now that this won't be our last pandemic. As a matter of fact, there's probably been 6 of them during my time practicing, epidemic or pandemic. That includes SARS, MERS, H1N1, Ebola, and COVID. And that's not even discussing the outbreaks that happen regularly around the world, flu, measles, cholera, things like that. So these are here to stay. So we need to prepare for this. We need to do things better in healthcare and deliver healthcare better to make sure that vulnerable patients don't always need to come to a hospital setting. Video consults, Zoom like this is extraordinary help. We also need to prepare in the fact that things will be disrupted. Our lives will be disrupted. We are now a global community. We often live a long way from families, and that makes it tough. Even things like transport gets disrupted. So all of us unearthed our bikes in order to get to and from work in many cases. Besides preparing, we also need to be flexible and embrace new technologies, or technologies that are perhaps old, like baby monitors, and bringing them back into hospital, using the technologies of online. And also, it's my sense that we're going to see a lot of breakthrough health technologies in this time. I know everyone's focused right now on rapid testing and on vaccines, but I think there's going to be a lot more in the middle space that teaches us how to do this better. The final learning point I would say is prioritize your health. And I could spend another hour talking about that, but I think it's something that we've all done, even subconsciously, during this pandemic. So that's my message for today. I'm really happy to take any questions if you have them.
Thanks a lot, Dr. Westrup. We have a question from the chat room asking, how has the virus impacted procedures for childbirth? Is there evidence of the virus crossing the placenta?
Oh gosh, that's a very good question. So first of all, I have to hold up my hand and tell you I'm not an obstetrician gynecologist or an expert in COVID, but I can answer that more generally. The COVID virus has actually made surgical procedures something that we really, really think about. So I'm sorry, I'm going to take your question and move it into the oncology world, but that's the one I live in, more or less. For most cancer cases right now, if there is abdominal surgery involved, we really think of whether we need to do it or if it can be delayed by any means. And that might mean giving chemotherapy first before entering the abdomen. It's also true for the chest because this is the biggest point of transmission. So our cardiothoracic surgeons doing lung surgeries, lung cancer surgeries, we're thinking not once, twice, but 3 times before we do it in any way that we can delay or do something different before we need the surgery. So it certainly has changed our way that we approach surgeries.
Thanks for that, Doctor. A question from me. You talked at the end there about preparation, and surely, as we're all seeing in the news cycle, there is more and more talk of, what is coming after this pandemic, and including how do we prepare. I wonder if you could just say a couple words about the future of public health, not necessarily oncology, but more broadly. What changes might we be seeing from our public health systems immediately following this pandemic, and in part in preparation for the next one?
Okay, so that's a great question. And I think there's 2 takeaway points I would take from this one. First of all is that we need to believe our public health experts when they start saying that there's a problem. I think as doctors, we started picking it up early, but thinking China's a long way away. So I'm imagining everybody was thinking a little bit the same thing, but we need to pay real attention. The second thing is we need to decide how much of our privacy we really want to protect. And I know that this is a slippery slope kind of question, but the question is our early warning system here was a 33-year-old ophthalmologist on an iPhone telling his friends what was happening. There are many ways to track and see pandemics happening around the world. There are even smartphone apps that take temperatures, and these temperatures are uploaded. There's Google searches, and if you follow the Google searches, people were searching these symptoms. But there's also the information that we hold about each one of us. Do we want to keep that? Do we want to share it for the public good or the public health? In Europe, we're really struggling with this issue called GDPR, which is privacy issues, and it has really affected the way we do clinical trials, audits, or any kind of retrospective research in hospitals and on patients. So I think the public health question is also a question of what we're willing to give ourselves.
Yeah, very fair point. Here's a question from the chat room. What things is Dr. Westrup doing to keep her team and her own mental health strong?
Oh, I love that question. Thank you for asking that question. So, we do a number of things. So first of all, we have a clinical psychologist attached to our team who's available to everyone. The second is we have a daily COVID meeting in our hospital at 10 a.m. The third is our occupational health is completely hooked in to our staffing. But the fourth thing is that we're protecting each other. So as we're walking around, we've elected to start a system where we critique each other's PPE or ability to put it on and how you're managing your own infectious risk. We're making sure that everything is wiped down, tabletops, computers, phones, everything. Hospitals tend to be very shared spaces, so we're trying to be sure that everything is clear. And then really talking about it every day. And that in terms of, when you go home, how is that going? What are you doing with your clothes? Are you leaving in the hospital and showering here? What are you doing at home? How's everybody feeling coming back to work? One of the biggest things when we split the teams in two, that also gave people a real sense of relief. We have right now low volumes of patients because we have created a lot of extra space within our system, but we have very high intensity patients. And so everybody needs to focus harder, and having a little more time off work is good.
Another one from our participants. How has the press in Ireland and the medical community been responding to the USA COVID efforts and leadership?
Oh gosh. Well, I think we're a bit surprised, to be honest. When I think about how quickly that this moved from China to the first cases in Italy, and we are, as Italy is part of one European Union, by the end of January, when they started reporting their first cases, we were already into COVID planning because we were all part of a bigger system, doing webinars between hospitals and supporting each other, and then going into lockdown. Now, really interestingly, Ireland's Prime Minister, or Taoiseach we call him, is actually a doctor. So a lot of the decisions were made fairly quickly. But when we looked to America, it seemed almost that everything that we were learning and doing and taking from people who went before us wasn't being translated across the ocean. And it's very hard to tell from the news outlets exactly what is going on, to be honest.
Dr. Westrup, you mentioned kind of in the looking ahead point about using new technology. Another question from me. In the last Ebola outbreak in West Africa, less so in countries outside of West Africa, but certainly there, big data played an essential role in understanding the outbreak, supporting medical professionals in kind of corralling it and dealing with it. Can you just say a couple more words, if you can, either from the oncology perspective or public health, on pandemic and the use of big data?
Yes, I can. I'll use some concrete examples. I mean, well, first of all, if you haven't gone to the Johns Hopkins coronavirus website, you need to go there today. It is an astounding example of great data that's being presented in real time. And remember that our data is based only on what we know, and that's who's been tested. And we know that there are far more cases out there than we know of and can test for. So I think first of all, this ability to globally collate data is fascinating, and I hope we learn a lot from it. I'm afraid one thing we will learn is that, of course, what we all know, we're not testing enough. So our data is a bit skewed. The second thing that's really reassuring is that we're creating our own data, in that one of the things that's happening quickly is we're creating a global clinical trial on COVID. And this is being passed from country to country and being started up in each country so that we can add to the global registry on our experiences, and then we can have a look back after this is done. So I think there are a lot of initiatives here that are going to be really helpful, but it'll take a while to churn that data.
Okay, Dr. Westrup, this is about all we have time for. Last word to you.
Listen, I think this is not our last pandemic, as I said before. And I think we have a lot to learn from this pandemic. But what I hope we learn as well is that maybe humans aren't made for social isolation. So simple things like washing our hands, cleaning our environment, and a little bit of social distancing, I hope will go a long way for the next time around. I'd also like to thank you and the Montana World Affairs Council for inviting me today.
It's been a pleasure. Thank you so much, Dr. Westrup. I mean, thank you for coming on. And thank you, and I have to say to all of the medical professionals in Ireland, in America, and around the world who are, as we know, risking their own healths and their own well-being and safety in supporting, you know, our entire population in dealing with this pandemic. So special thanks to you. Now, this Thursday, we have another Connect Montana focusing again on public health. We've got Kathleen McLaughlin, who's a former Beijing correspondent for Science Magazine. She's going to join us on Thursday at noon Mountain Time. So please join us for that one. And if you have any questions or comments, please feel free to send them to me at info@montanaworldaffairs.org. If you've got some ideas for another show or a possible guest, share that with me. Much appreciated. Thanks everybody for coming on. Everybody be well.